Okay, so now we have an opportunity to ask our wonderful panel lots of questions about the topics that you've just heard. So I think there's a couple of people coming around with questions. And also, if if you use Twitter and you want to tweet me a question because you're embarrassed to like write one down, then find me on Twitter and tweet me, and I'll try and sort of scroll through my Twitter feed to see if anything comes up whilst we do this. Okay, let's kick off. Let me see here. Neil, is there a blood bank standard for California RE platelet preparation?
So in Northern California, pretty much the standard is apheresis because there's a high transplant population here, there's a high oncology population. I know in Washington State, they don't do apheresis, they do pooled collection. And that's because they have a big trauma population and they have critical access hospitals that need products pretty quickly. And with platelets lasting, only 5 to 7 days, you have to make sure that you have enough supply chain to address all the needs.
Okay, great. Do you have when you're dealing with someone with gestational thrombocytopenia, is there a threshold that you personally would consider for a platelet transfusion, or do you do it on a case-by-case basis?
So my interpretation of the literature is that it's probably safe to do a spinal for a patient with gestational thrombocytopenia with a count above 50. Now, I'm more concerned about what the community here would think if I did that versus what would happen to the patient, because I don't think that our anesthesia colleagues are there yet. So, my sense of the literature is that it's probably safe, and I think a spinal pencil point 27 gauge needle versus an epidural, it's a very different trauma, and I think a labor epidural for labor analgesia is a very different situation than an urgent emergent C-section. One is I wouldn't say completely elective, but more elective than the other, and one's more traumatic than the other. So I haven't been in this situation yet. I'll probably, next time I'm on OB, I will have a patient with a platelet count of 49,000, and she needs an urgent C-section and has a horrible airway. But I think it's safe, and I do lumbar punctures in children probably once a week, and routinely I'm seeing these hematologists, do lumbar punctures in kids that have platelet counts of 10,000, 15,000, 20,000, and they're all fine. And I've been seeing this for 10 years, and in their literature, it's safe. So I just can't imagine that experience has no relevance to our practice. So.
Okay. Question for Andy.
So if we weigh in on that one?
Yeah.
I think, Andrew, did you want to comment before on this?
Go ahead.
No, go ahead. So I think one of the key things what you're hearing Neil say, really, the biggest thing is I think ACOG did us a disservice with their numbers. So they came over and said 80,000. And I'm glad that they actually did lower, but I really hate the concept of a number that's safe because it's all risk benefit. You have to weigh the whole situation. Nobody's going to come up to you and say, this woman has a platelet count of 40. What else is going on? What's her airway? All that thing has to be weighed into consideration. Have I done an epidural in a person with a platelet count of 50,000? Absolutely. Even though, like you just said now, that you weren't so happy, but I used my judgment in that, as well as consult the patient and explain the risks, explain the benefits, and we mutually came to a decision. I was sweating the whole time period. But I think what has happened is we've removed a little bit of that judgment issue.
I couldn't say it better. I do the exact same thing. So you have to weigh the whole situation, and I agree with you that other specialties have in their literature a completely different standard, and unfortunately we can't get away from this platelet count number obsession, and I hope we can get away and say it's the situation, that it's the scenario.
And I'm smiling because Andrea said that. I've been discussing this I've heard it since 1992. Yeah. Actually, that's when I was my fellowship. So when I was a resident in 1989, we were discussing it. And what's the safe number? You're absolutely right. I don't think in my career we're going to come away from it.
I feel like this question comes up every year at Sol Schneider, and I think we'll be hearing it every year until we're done. Okay, moving on. Andy, logistical question for you. Positioning babies during C-section. You talked about them going transverse, not vertical. How do you try and avoid disrupting the sterile field and issues with the surgeon for closure?
Right,
Is that a
okay.
problem?
Yeah, so, and this is, every patient is built differently too. That's the other thing, right? You know, you're gonna have some patients where this is easier than others. I think that with that, it's really, the two things that are really important are communication with everybody, patients and with the obstetricians, and then also that somebody has hands on the baby. Because, I mean, think about how horrible it would be if a baby fell. So, you know, we typically will do the vertical just because there seems to be enough space, and because we can tell our obstetricians, you know, the baby's right here, but if you end up going transverse, again, just somebody needs to be hanging onto that baby and seeing if that's even a stable way to do it. And if we're in the surgical field, then we work with a way to all be in the same place. Ideally, the obstetricians are completely on board with this, and if they're not, then we need to bring them to the table and talk to them.
Okay.
I hope that answers the question.
Yeah. Someone's actually written here, this is pretty impressive. At our hospital, we are out of the OR in 30 to 40 minutes after birth. Well, I want to work where you are. How do you give 1 hour of skin to skin when the mum is ready to go out to PACU? Do you move the baby on the chest for transfer, or
We do.
recovery?
I mean, first of all, you're very fortunate to be in an environment where your surgeons are that fast, because often we are nowhere near that. But like I said, we perfected a way to actually even move baby skin to skin, which made me completely nervous at the beginning, but it actually works quite well. It depends on how you move mom over to the gurney, but you can pull it off, and by pull it off, I don't mean pull the baby off, I mean accomplish it. You can do it, and we've done it with moving, and you could do the same thing. You can just leave mom on baby and then go to the newborn, to the ward, to the postpartum ward. And if everybody's on board, then all the stuff that they do to these babies, the vitamin K and all these other things, can be done on the postpartum ward. There's nothing that says it has to be done in the PACU unless that's what your institution does. And if that's the case, then again, everybody has to come to the table and go through the logistics of all of this. And I think that's, you know, the most important thing about it is what works at your institution.
Oh, so can I ask Andrew a question? Andrew, has there any literature on surrogates? I.e., somebody can't do skin to skin, so you have a sibling. My sister would like to do the skin to skin. Is there any literature on that?
There is, yeah, there is. The hardest part coming up with good literature to actually talk about was that, the N might be 5, so there's not a lot of really robust literature, but yes, it's there. And, I kind of alluded to that a little bit in the Swedish study where the husbands that participated actually scored higher on the relationship satisfaction questionnaire, that they were getting benefits of the skin to skin as well. So I think absolutely, and like you were showing that picture of the chest hairs in the OR, we see that too. And so, yeah, I don't think that it has to be mother.
So if my anesthesia resident wants to do skin to skin for the baby, I can take over the anesthetic and let them do skin to skin.
Then you can present that next year. You can talk about how we implement that as part of the residency program at the University of Kentucky.
I want to see a photo of that next year. Bob, when you come back, can you bring a photo, please?
All right, this is
I'm
sitting here, Andrew has me blushing. I am blushing so big time.
I can have a Learnly module on that.
Yeah, make sure that goes with the ACGME fellowship program. That'll be good. Questions for Bob. Can I use an LMA when I'm doing chest compressions for neonatal resuscitation?
So the answer is yeah, you can. I mean, it might not be because remember it's 1, 2, 3 breath, so you're not supposed to be doing compressions at the same time ventilating. So the answer is absolutely.
Okay. Another question about communication. You said that we aren't that great, or we can do better at it. Why aren't we that good, and what can we do to improve the situation when we're talking to OBs?
I'll take a step back, and I'll just reflect on my own practice. Until I read that study, I am very good at advocating. I'm having a difficult time intubating. I'm having a difficult time with the spinal. I'm not as good as leaning over the drape saying, how's it going? What do you think? You're going to be another 20 minutes? And I think one of the things that was done at my previous place that I've now trying to get at Kentucky is that every 30 minutes, there's a ping that goes off, and both teams are supposed to communicate, and it's well listed. And I don't know, it was just the fact that, I'm not saying that we are, but in that study, one of the things that they found was anesthesia providers are very good at advocating, not very good at inquiring. And I think one of the things that we have to do is that I learned that, and I have to change my students and make them feel comfortable. And I think sometimes the surgeons and obstetricians do feel a little threatened, but they have to realize too, it's not part of the threat. It's really just, we can provide better care knowing how much longer. Oh, okay, my spinal is wearing off. Maybe I should go to general or something like that. That's just my own personal reflection.
Can I chime in on that?
Absolutely.
So I think that part of that stems from the culture that we have in the main OR, where sometimes we feel like if we communicate things, we get maybe yelled at a little bit. And so we get our residents that come in and they're nervous. They don't know these people, and it's a totally different world. Everybody's awake, and there's this circus of the baby and all these people and the chest hairs and all this stuff. And it's really, you have to learn, it's a skill that we have to teach, and we have to model it. And I think that also when we work with the same people as much as we can, that they see that we are paying attention and communicating with them. I think so much of it is if our back is turned and we're on the computers, and we're not communicating with them, and we need to be watching them. I teach my residents that the field is your best monitor, the surgeon and the uterus, and it's your best monitor. So just watch that and communicate.
And I think it's comfort level too, that I'm much more of an inquirer up on OB, where I know the obstetricians and I know them very well, unlike when I'm covering ortho, where I probably haven't met the surgeon, and they probably came in when I was out. And and I think one of the most important things, which I try to teach residents at the beginning, introduce yourself and say, hi, I am. And I think that helps too, because then instead of saying, hey, surgery, and instead of surgery saying, hey, anesthesia, it's just, I think it helps in that regard. But I never thought about it, Andrew. I totally agree. It's that culture that starts right from our day one of training.
Okay, questions for Neil. Our hospital is still routinely doing CBC on all patients. Should I wait for a platelet count, even if it's cooking in a low-risk patient who's in advanced or late labor?
The ASA doesn't recommend getting routine CBCs for all laboring women. I would say no.
Okay. And I have to, sometimes when I'm dealing with a patient postpartum who's on an epidural for labor, if they have a low platelet count, people in our institution have been considering giving platelets prior to pulling the catheter for low platelet counts. Any comments?
Yeah, I think giving platelets to pull an epidural, it's a big risk that you're kind of kicking down the line for that patient. You know, if your institution is giving pooled platelets, you're exposing that patient to 6 to 8 sets of HLA antigens that may complicate the ability of that patient down the road to get further platelet transfusions, to get a transplant, to get a bone marrow transplant if they ever develop lymphoma. You're adding risks that you don't necessarily think about. You know, yesterday Dr. Scavone, she talked about how we shouldn't think of ourselves as just putting in epidurals and spinals and waiting for C-sections, but really advocating for our patients. And that part of that is not just thinking about the perinatal period or perioperative period, but the consequences, the lifelong consequences of what some of our actions do to make us feel better, but not necessarily decrease risk in the patient. So the idea of giving a platelet transfusion just to pull a catheter doesn't really sit well with me, but I understand if that platelet count is 5 or 10,000, you're not going to be comfortable pulling that catheter either. So it's a tough call. It requires judgment, and just realize that giving a platelet transfusion is not as benign as we all would like to think it is.
All right, questions for Bob. I like these ones. How do you get your surgical colleagues, how do you convince your surgical colleagues that it's okay to warm up the room, especially if you're dealing with a sweaty surgeon who's telling you that he might pass out or he's worried about sweating into the wound? Should you mop his sweaty brow?
Alex, and it could be his or her.
Sorry, yes, his or her.
Um,
Thank you.
I think one of I think one of the important things, boy, if you listen to what Andrea taught us, the most important thing when she instituted a real change, if you listened to what she said was, don't surprise, don't sit there and say it. You listen to what she said is get everybody in the room and to communicate. And I think that's one of the keys. To sit there and go in and turn up the room on Monday because, well, Bob Gaiser said it's important, I already can tell you're doomed to failure. And what Andrew said, bring them all together. And I think you need to come together with an educated and sit there and say, listen, this is what the literature has shown. And I think one of the key things is with teamwork and with discussion, that works. And I think that's our biggest problem. We try to do these changes and, oh, I failed. One of the things that is always on the checklist, what was one of the barriers? Well, the barrier really was poor communication, and it really always comes down to that. And as I've been a chair for 6 months, and I really have changed the way I do stuff. I started doing initiating, I would say, we're gonna do it this way, because I'm the chair. It failed big time. And it's, all right, let's meet together, let's discuss it, because ultimately we will get there, but it'll be even better.
One of the ways that we were able to get the room temperature up is that NICU came to us and said, our babies are cold and we got to do something about it. But we all had to sit down at the table and talk about it.
Recurring theme.
Actually,
Really
one
important.
of the reasons we found why the rooms went down is that after the C-sections, the cleaners were going in the room, turning the temperature down on the thermostat, didn't tell anyone, and we're going in the room with our patient for a section, wondering why the temperature is 60 odd degrees.
And when we implemented skin to skin, that was actually something I was really worried about, was babies getting cold, but the evidence does not support it.
All right, next question for Andy. Any comments or updates about breastfeeding for the opioid addicted mother?
Wow. I think, well, first of all, when we have that scenario, these babies typically go to NICU. We don't put them skin to skin unless they're doing well enough. Obviously, if they're withdrawing or something like that, they're not going to be going skin to skin. I think that the bottom line is that breastfeeding is always the best way to go. And at the beginning, there's not going to be a lot of transfer of the drug to the baby. But we usually work with our lactation consultants on that. That's actually a whole nother topic that SOAP has tried to address at various times, which is what drugs can moms take and still breastfeed. And so, I think that it really depends on the situation and the baby and the mom and what she's on and how much and how vigorous the baby is. Because often those babies won't even latch because they have other things going on, so.
Okay. Question for Neil. Do you use any testing, point of care or lab testing you talked about platelet counts, but what about function? Do you use any point of care testing or lab testing to assess function, maybe with TEG, even a patient with a low platelet count?
So in terms of TEG, there are TEG believers or TEG non-believers, or TEG hospitals and TEG non-hospitals, and I found that hospitals that don't use TEG, they have a lot of barriers to entry if you do want to get TEG implemented. I think TEG is great for the bleeding patient, post-bypass, trauma, liver transplant, to figure out why they're bleeding in terms of assessing platelet hemostasis in a non-bleeding patient. I'm not sure how useful it is. I personally don't use it. I think that information would be helpful in terms of making a judgment. It's on its own, there's no specific value that I would advocate for, but in terms of a constellation of data that you make a judgment on, I think that could be useful, but I'm not sure how beneficial it is in this setting.
For the group out there, how many people have TEG readily available? Who do not? Interesting. I switched, it's funny that Neil said that. I went from a place that was a non-TEG to where they do TEG pretty much for everything.
Right. And it's hard to get the non-TEG people to start doing TEG.
It is very hard.
Okay, question for Bob. You made a reference about people who work in hospitals where there's some requirement or contractual obligation they have to do resuscitation of the neonate, whether they like it or not. Do you think that neo-sim training for anesthesia CRNAs, residents, fellows is a good idea, if that might be a possibility.
So I'm always a big fan, because while it's not so much that in the thing, so I think everybody who works on OB should be trained in neonatal resuscitation, because you never know when you will be asked to assist in the resuscitation. What we're talking about is that your primary responsibility? So what happens is there's a lot of places where the NICU or the peds do not want to be available at night, and so they ask anesthesia. Now it's the anesthesia contract. Very great idea, until all of a sudden you realize you're responsible for the mother. And that is not the role of the anesthesia provider. The anesthesia provider role is to take care of the mom. The anesthesia provider is also obligated to be as skilled as possible to assist with the resuscitation, but I do not think should be primarily responsible. But if that's already in your contract, you have to be aware of it and watch out for that.
Okay, question for Randy.
May I say something?
Yeah.
Remember, sometimes fetal distress is associated with maternal distress. Case like a placental abruption, you can't leave your patient take care of that baby. So they go hand to hand sometimes, and it's not feasible to drop one to take care of the other.
How many people have resuscitated a newborn on their labor floor? Yeah, you can see. I mean, look at that. It's a fairly decent number have had it. How many do it at least once a year? Yeah. And so that's why I think we're obligated to stay as up to date as possible.
Question for Randy. This is a good one. I like this one. You talked about baby-friendly hospitals. If my hospital doesn't do skin-to-skin, then by default, does that make me baby-unfriendly, despite the other baby-friendly things that we do? What do you think about that?
Good question. I think Alex is finding all the tough questions, but no, no, that doesn't mean that you are baby unfriendly. What it means, again, I mean, we've all seen it, where you drive basically anywhere in the country and the hospitals have on the side of the building or on a billboard or somewhere, #1 hospital in the, tri-county area in this one thing. And every hospital, I mean, it's a competitive environment, and so they're trying to, find ways to compete. I think that's part of it. But I think that the important thing to understand is that the baby-friendly designation itself is very strict guidelines from the WHO, and if you look at it, there's a whole website on all the stuff that the hospitals have to do, and not surprisingly, they also have to pay money to be baby-friendly certified, and they have to. So it's a thing that they're all doing. So it does not mean that you are unfriendly. It just means that you haven't met the exact criteria that they have, and there were 10 of them, and I blanked out all the ones that didn't apply to us for a reason, because it's overwhelming. The other consideration with all of this, though, is our patients are very savvy. They've got 9 months to worry about all kinds of things related to their delivery, and this is something that they're looking for. So they may just say, well, I'm only delivering in a baby-friendly hospital. This one is and this one isn't, so I'm going there. And, never mind the fact that, the one that's not baby-friendly, has a higher quality of, nursery or immediate availability of, high-quality anesthesiologists. They're not. So it's kind of, we all should be implementing these baby-friendly practices, but whether we're certified, that's a different story.
All right, we'll make this the very last question, and we're sort of running out of time, so I need to make this short. What's your opinion about using uncross-matched red blood cells when you're dealing with a major PPH and the risk of HLA immunization down the line?
Yeah, in a life or death threatening situation, you have to forego some of the theoretical risks of HLA allosensitization to save the patient's life. So it's a judgment, right? I'm not going to withhold ABO incompatible platelets or ABO, universal donor red blood cells because of this issue. I'm going to do my best to save the patient's life. So it all comes on the judgment and the specific situation that you're dealing with at that time.
All right, great. And I think with that, we'll probably call it a day. It's 9:15, so we can all thank the panelists for excellent lectures and this wonderful Q&A.
And on behalf of the panelists, we want to thank you. There's nothing harder than getting the Sunday slot And so the fact that you came out to hear us, we really appreciate it. So on behalf of the panelists, we'd like to say thank you.
Okay, and I think we'll come back just about 9:30, so about 15 minutes or so. Thanks.